everybody. Okay, so I had a really happy introduction plan for this podcast because it's got Dr. Kelsey Thompson on, and I simply adore her. She is, she's this brilliant pediatric feeding therapist who does research, but it's clinical research. She works with UNC Chapel Hill and at Duke and with Feeding Flock and does amazing, amazing things. But I can't do the happy intro that I wanted because I just got this email, and I'm hoping that you too read this email. So if you don't, one of the things ASHA does for us is that they advocate, right? Like we have a significant ASHA pack. Well, you can actually go into your ASHA membership and streamline your email correspondences. So I have streamlined my email correspondences so that I get stuff on early intervention. I get conversations from the SIGs, which I know are getting involved, but I also get the ASHA advocacy updates. So this email came through at 13:31. So 1:30 this afternoon. It is Monday, June 9th. So this is current as of now when I am actually recording. The Centers for, and it's directly from ASHA Advocacy, the Centers for Medicare and Medicaid Services recently made an update. In short, ASHA received guidance from CMS that provisional licensure does not meet the definition of license for the purposes of Medicare Part B outpatient provider for enrollment. This means if you are a CF currently providing services to Medicare Part B beneficiaries, these patients must now be seen by a fully licensed SLP. So, I know we're an early intervention podcast. I know that we focus on the teeny tiny humans up through like middle school, high school. Sometimes some high schooler conversations come on here. But this is impactful because these are our speech babies that just graduated, that just started working or are coming close to finishing their CF. And this happened without warning, without prior knowledge. It just happened. So here's what we can do. One, as my grandma would say, put a prayer on it, because in all things, put a prayer on it. But two, please, 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 ASHA has numerous avenues that you can advocate. You can hit the learn more button on the email. You can go onto their website. They have ways that you can send a pre-populated email correspondence to your representatives, to your senators. You can pick up the phone and call them. My big scary fear is that if they're doing this for Medicare Part B, are they going to start trickling it down into other avenues, and is Medicaid going to be placed at risk? So this is not good. You guys, this is why we advocate. So please, please, please reach out, support, and advocate. I know you may not be delivering these services, but the writing is on the wall. It could impact us all. And I did not mean for that to rhyme, because this is a bad time to have rhyming or alliteration, but like there it is. Other than that, if we switch gears into happy news, Miss Waffles Adelaide Puppykins Dawson has joined the pack. And she's quite possibly the cutest dog. She is Artemis cute, not Aphrodite cute. That's what my children describe it as. So Artemis was the goddess of like hunting, and Waffles thinks that she can hunt butterflies and leaves and flies. So she is sporty cute. And they're like, but dog was beautiful like Aphrodite. Also, in unrelated news, my oldest is rereading all of the Percy Jackson series. So we've got a lot of Greek gods going on in our household right now, which is like making me dust off all of that brain power that I dedicated to it at about the same age. So huzzah for neurodivergent families. But like, yeah, I still want to grow up and be Athena. But yeah, that's kind of it. I wish I had better news, but alas, that I really don't. Um, please advocate for our profession. And I truly do hope that you enjoyed today's conversation with Kelsey, because she is a ray of sunshine, and God, she's going to do great things for our world of pediatric feeding disorder. So enjoy that, and know I will be right there alongside, advocating with us, and we shall see what next episode's intro has. Oh my God, I completely forgot. It's Dysphagia Research Society. That was my fun one. We still got to work it in. It is DRS. Join the First Bite team. Come run with us virtually on Saturday morning. If you can't run with us virtually, then or you could walk, run, stroll, bike. You do you. You could swim a lap in the pool. I mean, I think that's the equivalent. You're moving your body. You're raising money for dysphagia research. But we do have a First Bite team, and all funding does go towards their research. And currently, National Foundation of Swallowing Disorders, Dysphagia Research Society has they fund clinical research across the life continuum, as well as research. And it's been kind of cool to see our field moving forward, because National Foundation of Swallowing Disorders, which is a separate entity but also has a bunch going on for Dysphagia Awareness Month, they have been helping to push through to get clinical trials for a actual implant that would help with dysphagia management. So it's a really cool, I mean, for adults, but like, it's a really cool time to be working professionally within the world of dysphagia, as long as we can get insurance to continue funding our work. So yeah. All right, back to the side. Nope. Let's choose happy. Enjoy Kelsey. And if you have an idea for a speaker, a topic, research that you want to uncover, policy change you want to learn more about, then let us know. Message us on the First Bite Instagram page or on the First Bite Facebook page, or give us a call. All right. Enjoy, y'all. Bye. Everybody, thank you so much for joining us. I am utterly tickled pink by today's guest and our topic. We have our very own Dr. Kelsey Thompson, who I met a lifetime ago when she was getting her PhD, and she did this while raising and having two tiny little humans. Honestly, Kelsey, the only other woman I know to do this was Rachel. So like you and Rachel and like tiny baby mom life and PhDs. But Kelsey is a speech language pathologist. Her heart is in that clinical work. She was a clinician first. She's a research scientist. And today we're talking specifically about her most current research on working with infants that have Down syndrome and preterm infants and their families. But I have had the pleasure of working with Kelsey for the last 2 years on the Pediatric Feeding and Swallowing Disorders Topic Committee with ASHA. And I think my favorite talk that I've seen you give is the one where you analyzed intervention outcomes. And you handled that so diplomatically. And I was like, oh, yes, this is well done, ma'am. And full disclosure, I know it's May when this is coming out, but she said yes and is actually recording with me on my birthday. So huzzah for turning 42, and Hitchhiker's Guide to the Galaxy, it is the answer to everything, just saying. But Kelsey, thank you so much for coming on, and for today too, so yay.
Yeah, thank you so much for having me. I'm so excited.
Yes, well, I adore you, and you teach with such kindness and compassion that I don't know. Sometimes I watch folks and I'm like, oh, that was great, but I I didn't feel the warmth, right? But with you, there's always warmth. So take us from the beginning. How did you become a speech therapist?
Yeah, that's a great question. So I thought I wanted to be a teacher. I always wanted to be a teacher. I knew I wanted to work with kids. That was a given. And then in high school, we had the opportunity to go in and teach a lesson to a group of first graders. And I was like, oh, this is too many kids. I don't
Yes,
want
it is.
25 of them. I want like one or two at a time. which was a good lesson to learn before going to college. So I found speech pathology and shadowed someone when I was in high school. And I mean, went in from my freshman year of college knowing that's exactly what I wanted to do. I had no idea the breadth of work we did at the time. But that only kind of furthered my love of the field and all the different age groups and topics and areas that we can cover. So that's how I ended up in speech originally. Just really a love for kids and supporting children, and then narrowing it down to what I could do that with just a few of them at a time.
I was going to say, I could have seen you as a kindergarten teacher. You remind me of Miss Keene, who was one of my favorite kindergarten teachers to work with when I was a speech teacher, like 20 years ago. But where did you go to school?
I went to Northeastern for my bachelor's and master's up in Boston. Um, mm-hmm, and really
There's
loved
so the Northeasterns and the Northwesterns, I get confused. So thank you for clarifying the city.
it.
Well, how did you end up in North Carolina for your PhD then?
My husband is from North Carolina, and so we had met when we were both in DC after I had graduated and moved to DC, and then we dated long distance, and that only lasts so long for us. And so I moved down here to be with him. He was in Raleigh at the time, and so UNC
Nice.
it was. Yeah.
Okay, so UNC has the feeding flock. And for
Mm-hmm.
those of us that are not as familiar with the feeding flock, can you tell folks what that is and what work happens there?
Yeah, absolutely. So the feeding flock started with a core group at UNC. Sue Thorey, Jinhee Park, Haley Estrom, Kara McComish are all part of that original group of the feeding flock. And it really started as development of different tools. So many of you are probably familiar with the Neo Eat, the PD Eat, the Chomps, Fam Feed. Oh gosh, I'm gonna miss some. There are more. Look on the website. So it started as a group that was developing like really validated parent report tools for feeding assessment. And now it's grown to kind of be a collective of people who have similar goals and who are sharing work related to feeding research in that earlier childhood period.
Yes. And is that what brought you there to get your PhD? Is that what made you curious or?
Yeah, I mean, I hear from a lot of people it's hard to find places to do a PhD that where you can focus on pediatric feeding because there's not a ton of us out there.
Mighty but mighty. Yay.
And even less that are in a place where you can like mentor PhD students or have the funding or support or programs at your university for that. Particularly like as speech pathologists, like a nursing PhD program won't take a speech pathologist because you don't have a nursing background. So it kind of narrows the pool a little bit. But I had the great advantage of being able to do my research in nursing with Dr. Thorey, and also have a home in a speech pathology PhD program and have lots of great mentors and colleagues there too.
That's amazing. I love it. So, how long before you pay it forward and become somebody else's PhD mentor? Is that like instant? I've always wondered that.
I do. I mean, I really love mentoring students. Right now, I've mostly been doing master students because um, I have a 1 year old and an almost 3 year old. And so I'm waiting for them to get a little less needy on my time. But I love,
Okay, on behalf of the 10-year-old and 12-year-old mommy land, it's the need changes. They stay equally needy. It's just like the request varies. But continue.
I have heard that. I was hoping that it was not.
No.
Still just as much.
Well, Goose Changer, I mean, my kids are neurospicy, but like when we were at Feeding Matters, the time change, Goose at 7 to 7:15 wants to cuddle in my bed to read with me. And so we're like crossing the street together, like me and a bunch of people. And we picked up all the quilters. The Quilting Association of North America had their conference at the same time. So imagine little bitties with electric plaid print. This is my future, right? And so Goose FaceTimes and he's like, I'm in bed to snuggle and read with you and you're not here. And all of the quilters were like, oh, because he FaceTimes in downtown Arizona and I'm going to answer. But like, yes, so needy, but same. But so you're mentoring grad students for like clinical practicums or for
I was
what?
doing clinical practicum. So when I was getting my PhD, I was still running my private practice. And so I would take students through that and mentor master's students. And now I'm mentoring students for their research practicums.
That's awesome. That's
Yeah.
awesome. Okay, so all of that leads us to the topic of today, which is working with little ones that have Down syndrome. So, and this is something that I know you and Amy and I presented on at Feeding Matters about kind of along the same vein, but different aspects of, because it's something that's near and dear to our heart. But what made you fall in love with this specific population?
Oh, I have adored the kids with Down syndrome that I have worked with since the very beginning. I still remember in one of my clinical practicums in the schools, it was like my first one that I was outside the university clinic. And I had a pair of kiddos who had Down syndrome who had been in speech together for, probably since they were in kindergarten, and they were like fifth graders now. And
Yeah.
oh man, I just loved the relationship they had with each other. I mean, they'd push each other's buttons because they knew exactly how they had spent a lot of time together. But they were just so sweet. And all the families that I've worked with kids with Down syndrome, I mean, that community is so beautiful and connected, and
Yeah.
so supportive of each other. Unlike, a lot of communities that I've been a part of or have seen, which only furthers, you just see how passionate and connected they are and want to support and help nurture that in any way that you can.
Yeah. Yes, that's sames. Some of my little ones that I've had that have Down syndrome tend to have the most subtle underlying medical complexities that are often like it's missed because we unfortunately what I have encountered working with individuals that have Down syndrome but in more rural populations where we're not conveniently nearby like major medical facilities is that the subtle medical things like level 1 laryngeal cleft or Hirschsprung's that might, and I've seen kids not get diagnosed with this until they're 4, 5, 9, and but it all interconnects with why they have a pediatric feeding and swallowing disorder or um, and it's been humbling to be able to advocate and navigate along their journey. So,
Mm-hmm.
on that note, I know you mentioned it earlier that you have really, and Feeding Block in general, have really been working with that early feeding period, that birth to 3. But talk to us about that, why those moments are so impactful for like long-term health.
Mm-hmm. Yeah, I mean, this is the period that I'm most fascinated by, curious about, think can be really impactful. I mean, there's some things that we know about that early feeding period just from a child development standpoint. I mean, physical growth, there's a super rapid period, right? You have these tiny little babies, and then all of a sudden they're 3 and they're big.
Toddler.
They're like little humans, really little humans. Um,
Okay, I have a mom question for you. I remember changing Bear or Goose's diaper when like I was like a day before I gave birth to Bear, and I was like, we'll get to potty training. He was 2, and then the second Bear was born, and I changed Goose's poopy diaper. I was like, you're a beast, and now you're getting potty trained. Did you have that mom moment?
Yeah, we potty trained her when Rory. So my oldest is Zoe, younger is Rory, and we potty trained Zoe like when Rory was like 2 or 3 months old, and everyone thought we were nuts. But I was like, nope, I'm done. I can only do one kid at a time.
Okay, good. Because I've said that to some moms and they look at me like I'm crazy. And I'm like, no, man, it was like infant poop versus toddler poop. And toddler poop and infant, those are two different size poops. But
Yep.
yes, yeah,
Yep. I'm like,
sorry.
sorry, kid. You're being potty trained. She also was ready, but yeah, I was
Yeah.
also ready.
But but you're right. Those they do grow so much and so much changes from um suck, swallow, breathe to mastication patterns to everything in between.
hmm
And so what are your favorite aspects of growth there in that and with those tiny ones?
Yeah. So, I mean, I think one piece of it that I love is that like feeding skill development. I mean, it's just amazing that they can go from nursing or bottle feeding. They have that sex, swallow, breathe, narrow down, and then you introduce complementary foods, solid foods, and they develop a lot of skills. I mean, I was doing my dissertation while I was introducing solids while I was introducing solids to my oldest, and then just went through it again with my now 1 year old. And when I look, obviously, I took a lot of videos because of them eating. And seeing them when you first introduce, like around 6 months, and then what he's eating at a year, only 6 months later, like we don't learn anything that fast as adults. I mean, we are slow learners compared to these little ones. It's really, really amazing.
Yeah.
Yeah,
With
so
with
I love seeing that skill development, and then the feeding relationship between parent and infant, I think is also just a critical part of, when they're infants, you're making a lot of the feeding decisions for them. And they're not usually, I mean, some of our kids are telling you very clearly that this is not working, but for our kids where feeding's not an issue, they just, mostly go along with it. They tell us when they're hungry, but it mostly works. It works for them. But then all parents and infants, when you introduce solid foods, all of a sudden you're like, oh, they are becoming more autonomous. This is a relation, this is a
yes,
negotiation. What is this going, like, we're going to start setting the stage for, like, especially if it's your first child and you're navigating it for the first time, like, what is this going to look like? Who's going to make the decisions here? Is it them? Is it me? How do we come to an agreement? You have to meet in the middle somehow. So I love seeing that part of both the infant realizing, like, I have a say and I can make some decisions here. And also the parent learning how to respond to their child, what their cues are like now, and how to navigate that relationship as it changes, which I'm sure it never stops changing.
it's that, folks. That's where, if you're listening to this and listening through an early intervention lens, it's the attunement and attachment psychosocial piece, right? It's how are we picking up on those first hunger cues, like those first little root sounds, like when they're asleep. My favorite mom fail story for bringing in purees was, I Goose is going on 13 now, right? But it was, you introduce a new food and you do that new food for 3 days to try to rule out, if there's any food allergies. Folks, this is not current best practice, but this is what Michelle knew way back in the day. Do as I say, not as I did. So I gave him prunes for 3 days in a row because I didn't know any better. And by like the second day, he was losing his freaking mind. And the nanny, I mean, we were 2 states away from like any like family members. So it was just me and Christian. And bless my husband's heart, feeding is not his thing. And so the nanny who lived literally at the bottom of the hill, we called her Gaga. Gaga, I called her one day and I was like, I don't know what I'm doing wrong. She's like, bring me that baby now. And so I brought her Goose and she's like, now go home and sleep. And I went home and I napped. And then I came back and he was fine. And I was like, what did you do? She goes, you don't want to know the amount of junk food I just gave your child, but he's going to be okay. And don't give him any more prunes. And I was like, yes, ma'am. But I learned, just don't ask the Gaga, right? But yes, so attunement and attachment, I learned new signs of I don't want to eat this, but always, there's best practice and then it evolves. So yeah,
Mhm.
2.5 days in a row of prunes. Oh my God, what was I thinking? Yeah.
Yeah, you don't know. You don't know until you know.
The same for our parents when they're figuring this
Mhm.
out. And but within the population of Down syndrome, that early feeding skill set is also predicated on like their gross motor and fine motor skills. So do you
Mhm.
see like different ages of acquisition for some of this? Like what is the research telling us?
So we just did a scoping review of all the research that we could find on Down syndrome and feeding before the age of 3. And what we found for introducing complementary
Wait,
foods is, oh yeah.
I have a question. Scoping review. For those of us that aren't in research, can you explain what that is?
Yes, yeah. So you're probably familiar with a systematic review, which is you have a very narrow research question and you find all the articles that might answer that research question and then you analyze. So a lot of the examples here are like an intervention. So, like, does X intervention work? You find all the studies on that, and then you can kind of say, okay, we have a whole group of studies and we can make a determination, did it work or not? A scoping review is broader. The focus or the purpose of it isn't to answer a specific research question necessarily, but really to see what's out there, what's available in the research regarding a certain topic, population, or question. So for our scoping review, we were just interested in like what research exists around Down syndrome and feeding in the early feeding period before age 3, really because as we were trying to research it, we couldn't find much. And so it's
Yeah.
a good test of like, are we just not finding it or does it not exist? So you do go through the same systematic process of search terms and screening and all the steps to make it a very systematic process and identify all the articles you can. We found 40.
That's not, that
That's
doesn't
it.
feel, wait, the immediate next question is, were they speech therapy dominant articles or did you find more of them? Yes, this is what I've been saying. We have to get out of our scope interprofessional education. So where did you pull
Mhm.
more of your research from?
Yeah, a lot of it came from nutrition. Um, a lot of it
Interesting.
came, yeah, so a lot of it came from nutrition. There was some like texture studies kinds of papers. We did not set an age, like a limit on the year of publication. So I mean, we had our earliest articles from 1976. um, a lot of the
I know
early
how that is because my husband was born in 78, but continue.
So, like the research wasn't as sophisticated or sensitive to this
Uh-huh.
population then as it was now. There was, some concerning messages about what they thought about parents and things that you wouldn't, really, we wouldn't bring forward today. We know better. So, I mean, 40 articles to cover breastfeeding and complementary feeding, and we also looked at like feeding styles. That's not a lot of
Not,
research to exist ever
yeah.
related to this population.
So it begs the question, oh my God, my brain goes 14 different ways. Are y'all going to turn around and use this as a basis for research in this area?
Mm-hmm. Yeah, so that's our goal. We're writing up the publication now, and a major part of scoping reviews is identifying gaps. And so I'm working on a grant application to address one of those gaps. There are lots of them to fill, so there are a lot of opportunities for future research. But that's our goal, is to strengthen the literature. You asked about like speech pathology and like articles related to that. We didn't include articles that were only dysphagia, but that was most of what came out of our field related to this population, was just identifying dysphagia,
So
which is important, but not by any means the whole picture when it comes to infants with Down syndrome.
I wonder if that's because of the advent of the PFD diagnosis code, like the ICD-10 code only being, well, I mean, this year it's 4 years old. So I'm kind of curious if like
Mm-hmm.
that's why like the bulk of it was in dysphagia. were they actually looking for dysphagia, or was it that was the term that we had at the time? You see what I'm saying?
Mm-hmm. Yeah. A lot of it was that we found, like instrumental studies of, doing swallow studies or chart, but there was a decent amount that were like chart review studies, identifying, but it was dysphagia, probably partially, like you said, because that was what our term to describe it was in our field.
Yeah. But
Mhm.
as you mentioned, the articles that were done in the 70s that encompassed, I'm sure, a whole lot of isms and biases
Yep.
have evolved. And so too will our research. Yay, God, let's make it better. Okay. But when you were going through this and identifying the gaps, were there key transition points for these little ones that you were like, this we have to hone in on? Like, these are um, the biggies that are little ones are at risk for.
Hmm. I think one of those transition points is just the very initial feeding. So we know a lot of our kids have early hospital stays and they might have either initial or ongoing tube feeding.
Yeah.
Um, Breastfeeding is very possible for this population, and yet parents are not often supported in that goal. And that was a theme of a transition point where maybe parents wanted to move toward breastfeeding or partial breastfeeding. Um, and they really had to do, the qualitative studies showed they had to do a lot of advocating for themselves, for providers to believe that, babies with Down syndrome could be breastfed, which is sad and disappointing that parents had to do that much advocating. They were often told, like, no, it's going to be too hard. It's, not appropriate. And so that's an opportunity for support and growth. And we can talk more about that later. But that's one transition point. Something we did not find a lot on was bottle feeding in general. Um,
Interesting.
yeah, like there's just nothing on. There's lots on breastfeeding, which is good, but almost nothing on bottle feeding, how parents could be supported through that as well, and not on tube feeding either. So there was nothing like helping parents navigate the transition or combination feeding.
But
um,
then that trickles directly over into intervention and therapy. Like, if we don't have a basis, a solid basis for the research, then where are we extrapolating our intervention approaches? Like, where is that evidence based triangle coming from? So,
mhm.
wearing my CLC hat, I can tell you, and I know it's been 6 years since I took the class because my renewal is in May, which means I need to take some CEUs for my CLC class. But when I did my CLC 6 years ago, they the design format was an intensive week-long class, like on site at a hospital. It was a mommy baby friendly hospital. I can't remember the initiative,
Oh
but it
yeah,
was like
the baby friendly hospital. Yeah, it's like
friendly hospital.
mm-hmm.
Yes. So I did it there in Charleston, and because I drove down for it, but we had literally an hour and a half on special cases, and that was it. After taking 8 hours for 4 days, 3 hours for one day, and all of it, but we only had an hour and a half, and it included craniofacial, cleft palate, and babies with Down syndrome, and that was essentially it. But what I took away from that was our instructor was like, this is a special niche population that, and she said it, these babies with Down syndrome can be successful, but you need to take additional coursework on this. And it was kind of,
Mm-hmm.
it made me think back to when I'm teaching the PhD class and I'm like, I can't give you everything you need in one semester. So you have
Mm-hmm.
to pursue the coursework. But at the same time, there's not been that much coursework within the CLC breastfeeding world on it either. So yeah, no, I hear what
Mm-hmm.
you're saying.
Yeah, so there's a need there. I mean, that's within the first 6 months ish, a big
Yeah.
possible multiple transition points as you move through hospitalizations or additional medical needs, and then also through, are we, there might be changes in bottle feeding, breastfeeding, tube feeding, and what that looks like very early on. And then you come to complementary foods. When do I introduce them? What foods do I offer? What approach do I use? And then you face multiple decisions every single time you introduce a new texture, which is like, what's the best way to do this? How are they going to react? Let alone cup drinking and self feeding and allergenic food. I mean, there's and then like we talked about earlier, the parent child feeding dynamics are in there too. So that transition point is really, I mean, there's so many decisions to make as a
Yes.
parent of a neurotypical child, let alone a child who might have additional needs or need supports or a slightly different approach
Or have
than.
heart surgeries coming up because that's
Mhm,
huge with this population. Yes.
mhm.
Uh-huh. So
Yeah.
what when you're doing those anticipations, like going through, like for me going into clinic on Wednesday when I have my little one that has Down syndrome that comes in and like I'm helping them navigate, what what kind of support can I do or coaching can I do to kind of help them navigate the next upcoming transition?
That's a great question. I think for nursing, it's going to be like your feeding matters taught, like a heavy on the medical,
Yeah.
um, honestly, and also heavy on what are the parents' goals for feeding, what feeding is going to look like, and their priorities. I always say, regardless of the population, I totally respect that sometimes parents are okay with how feeding is going, even if it's not age appropriate or best practice, meeting the standard guidelines. They have, you have a bandwidth, and there's a lot of other things in your life and your child's life going on, and it might not be a priority. And as long as they're, you know, meeting
Really?
their nutritional needs, then you know what? It's okay to push it for a little while. If that's what that family and child need right now. I think it's so important for us not to put too much pressure on families to address things that they're not ready for or don't have the bandwidth for. I remember a family I worked with that had two autistic children. One of the kids I worked with, one of their son had a super limited diet, and I was like, I do feeding therapy too. And dad's like, you know what? It's just, it's working for us right now. And we have so many other therapies. And I totally respect that. Like, I'm here if you need me, but also if you don't have the bandwidth right now, that is okay too. So I think listening to families about what their feeding goals are, especially in that early period where a lot of the medical stuff is coming up, and following their lead with that. Like you said, connecting with appropriate lactation professionals who are trained in this population is super important. The research that we found said that, with good support, parents of children with Down syndrome can achieve their breastfeeding goals at similar rates as neurotypical children. So it's possible if that's a family goal. I don't know, though, the challenge might be finding people
Yes.
who are trained to support that.
Yes. And one thing that I have found is that making sure caregiver goals align with what the child developmentally is ready for.
Mm-hmm.
And that, so when they're telling you their goals, do their goals actually match? And
Mm-hmm.
that can be I'm picking my words wisely here. You see this, right? I have some families that see their child and see where they are, and they're like, just like you said, we're right here and this works. And then others that may misunderstand some of the information that's being told to them just because they're not familiar with it. Um, or the medical situation could be so rapidly evolving that it's hard for them to keep pace with it. And
Mm-hmm.
and y'all, there. we know that there's a breakdown between early intervention and access to medical records. So a lot of EI providers aren't given full information about what the potential heart defect could be going on, if why the child has a feeding tube. And so I say all this because when you start your eval process, please obtain consent to release information with the PCP and the medical team. So that way you can have improved continuity of care to get everybody on the same page with what are realistic goals during those key transition periods to make sure everybody's working together. I don't know. Also,
Mhm.
the watching the OTs and the PTs bounce the babies on the balls, and I know that's not really what they're doing, but like they bounce the babies on the ball for like core development and core strength and posture and diaphragmatic strength, and it's that that has merit to the child's ability to sit upright, to cup drink, to use a pincher grasp to bring food to mouth. All of that's interconnected.
Yeah, that reminds me of a kiddo I saw early on when I worked in early intervention when I first moved to North Carolina. And I it was a 1 year old with Down syndrome, and I went in and she wasn't sitting up yet. She was
Oh,
tube fed. And speaking of that, like caregiver goals and also the continuity of care, I was like, there has to be a medical and therapeutic history here. I'm not surely not the first person to see this infant, but mom wasn't really familiar understanding what the process was going to be, or even what the medical history had been. She wasn't in the medical field; it was kind of new to her. And her goal, she had started feeding the baby Cheetos,
oh,
and
bless.
yeah. And she's like, she really likes them. And I was like, you know, like,
That's as good as me giving you foods.
you see your face, but inside you're like, oh goodness.
Poker face,
And
yeah.
yeah, we're like, okay.
Oh, good.
But it was a process of like, okay, I need more information on this baby and what has led them to this point, and what, while also incorporating mom had, had clearly had feeding goals and coaching her around maybe what was more appropriate at this point, or like, hey, let's talk about ways we can get her to the foods that you're hoping that she'll be able to eat. Or but a lot of, there's a lot of pre work that needs to happen before we jump to Cheetos. uh,
Although I do love me some cheesy poofs. So like, but yes, yeah. We had years and years and years ago, I worked with a family that had moved from Virginia to South Carolina. We were both Virginia transplants and Army, as it would have. Her husband was Army, my Christian was Army before us. Well, me and family. Um, and over the course of working with our little one who had Down syndrome, he got diagnosed with infantile spasms.
mm,
Very, y'all, that's a very intense seizure disorder. IS, in most cases, evolves to LGS, Lennox-Gastaut syndrome, and his transitions along that way. But his treatment approach was getting placed on the ketogenic diet. And the ketogenic diet is high fat, low carbs. Y'all, this is not a weight loss diet. The ketogenic diet for seizure management is to reboot how the body metabolizes, and it's incredibly intense and can have a whole host of GI tract issues and those kind of things. I went out on emergency bed rest with Bear. So this is 10 years ago, 10 and a half years ago. And the woman that replaced me, and we looked hard to find somebody who felt comfortable taking on all of his etiologies, gave recommendations for that given his chronological age of 1, and he was not sitting up, we were not rolling over, his seizures had brought him back to like that of a 2 to 3 month old, that he needed to be working on puffs and crunchies and practicing chewing. And luckily that mom was a medical researcher,
Mm.
because she shut it down and was like, this is not on the approved ketogenic diet. Because, yes, I hear chronologically he should have been doing those things, but developmentally we did not have the prerequisite feeding skills. Also, medically, when we're looking at like the four domains of PFD, he had a very specific diet being managed by the registered dietitian, so the nutrition side, to keep him in a state of ketosis, and adding in the puffs were carbs that could throw him out of ketosis. And so, in her attempt to do great to work on feeding skill, we were missing these other critical elements because it was a unfamiliar, uncommon diagnosis. She did not. The mom stopped it and shut it down. But I say that because it was pre PFD diagnosis, and it was all of these factors that, yeah, key transition stages, but we were not there. Um,
Hmm.
yeah. Yeah.
And that's, I think, a great point too, is that we think about these key transitions as ages, but they're
Yes.
not ages, they are stages. And they're going to be shifted for every kid, and particularly for our kids with Down syndrome, based on their unique constellation of things that they have going on. And some of them, I mean, it's the perfect example, but in the research, they report the age at which kids were introduced to complementary foods, these kids with Down syndrome, and the range is ridiculous. It's like anywhere between 4 and 36 months is first introduction. And that's because each kid has their own, like, my nutrition colleagues were like, that's ridiculous. And I was like, that seems reasonable to me.
Yeah.
Like,
Okay, you call it complementary foods, and I'm
mm,
thinking baby foods. Can you explain the term complementary food?
yes, complementary food is really just the addition of foods other than breast milk or formula. So we also think of them as quote unquote solid foods. But complementary foods kind of covers like the full texture continuum. Some people in like the global nutrition space also include other drinks as complementary foods as well. So like milk, um, teas, things like that. When I think about complementary food, I think about, anything ranging from the very first very thin purees all the way to, an adult diet. Like you think your whole IDSI spectrum.
Yes.
Um,
Having just gotten back from Tennessee, we were joking around about the amount of times people found Mountain Dew in a baby bottle. And I'm like, yeah, okay. Also not wrong, but yep. Okay, wait.
mhm,
So, with my interpretation of when you use the term complementary food is because the infant is predominantly taking their calorie count and nourishment from formula, breast milk, um, tube feeds, and that this
mhm,
is to complement the primary form of nourishment for them to learn that skill set. Because when you first give the baby the spoon, they're going to stick it out because that's how they pump off of a nipple to extract the milk. So it takes them times to learn that skill set. Is that a
mhm.
good analogy?
Yeah, exactly. Yeah, the idea of complementary food is exactly that. That at first it's complementary or in addition to their primary nutrition source, and it's really just for skill development. We know for typically developing infants, usually around one, it becomes. I mean, we still call it in the literature. It's still called complementary food, but they're getting more and more of their nutrition from solid foods. The balance starts to shift. Um, and but for our kids with Down syndrome, it might be complementary for a much longer period than it is for our neurotypical kiddos,
Yeah. Yes.
as we
Yes.
have that more time for skill development or shifted timelines, or like you said, they start complementary foods and then a surgery happens, and you go back and forth, navigate.
Yes. And that's okay. So, folks, clinically, what that means is you are not married to your plan of cares and to your goals. Your goals should and will shift according to the child's overlying or baseline health conditions, right? And so we have to be prepared that as that baseline changes for better or worse, that we have to be prepared to update plan of cares. On that note, I should probably make a mental note. I need to write a plan of care for a little friend for today on change. But yes, but like those aspects are so critical.
Mm-hmm.
And I remember when I first started out writing goals that, child will accept like uh, what not ITSE mode, but like regular consistency foods, like so many trials and da da da. And then when the kid didn't make the goal, it was what have I done wrong? Why are we not making it? And I internalized it, right? And it was me trying to take textbook knowledge and marry it with like real world with these little ones that have so many other things happening in their lives. And just like you said, the caregivers have so many other things happening in their lives. And yeah,
Mm-hmm. I
yeah.
always say, I have told many people this, that after I had kids myself, I was like, whoa. I was like a little optimistic about how much caregivers can do. And like the families I was seeing, I like after I came back from maternity leave, I was like, I am so sorry. That was ridiculous. And they're like, no, you're fine. I mean, I've always tried to be collaborative, like, hey, tell me if this isn't going to work for you,
Yeah.
But I had a new appreciation for it after I became a parent myself. I was like, wow, yeah, that was that
Yeah.
was not that was not realistic.
Lana told me one time I was pregnant and I was leaving her house. I was pregnant with Goose, and because I worked with her grandbaby, and she turned to me. She goes, "Sugar britches, I can do one new thing a week, just one." She goes, "So you just told me 10. Pick one," and I was like, "Oh, but okay." And so I took, rattled through my ADHD brain and picked out like the one that was like I thought the most important, and that stuck because as a mom to a 10-year-old and a 12-year-old, there are weeks when I cannot do one new thing because I have so much on my plate and it's
Mhm.
ah everybody breathe, give yourself grace, dust yourself off, and then we'll go figure it out.
It's a good
Yes.
reminder. I like that one new thing because I always thought it was like giving people options, or especially as a new clinician, I think sometimes we feel like I have to show them that I know things so that
Yeah.
they trust me. Um, but they already trust you. They'll
Yeah.
probably trust you more if you only give them one thing
One
at a
thing.
time. Yep.
One thing. That's and oh gosh, who was it? I can see her face. I think her name begins with an E. Not Marcia. She's a younger clinician and all about. I had her on the podcast forever and a day ago, and she talked about our to-do list versus our must-do, and transitioning from I have to do all of these things to this is my must-do for today. And oh my God, I will think of her name. But that was so helpful to me as a human to transition.
Mhm.
And it supported the one new thing a week for my caregivers. So, yeah.
Yeah,
Yeah.
so important.
Okay. So, in light of that, when we're working with them, let's go down the rabbit hole of like what resources can we I got so excited about like what resources and how to support them. Did we cover everything in the research realm that you wanted to cover?
Yeah, I think so. I mean, really, what the research shows from what we have, which is granted, like I said earlier, not a ton, but what we have, I really want to highlight like two main things, which is one, infants with Down syndrome can absolutely breastfeed if that's part of the caregiver's feeding goals. And, it's going to be a different look differently for every infant. But I think that there's an opportunity to support that maybe, I know as a new clinician, I mean, when I was working in EI, I saw an infant with Down syndrome and the mom really wanted to breastfeed. And I was like, I don't know if that's, I didn't know because I didn't know. And luckily she was able to, but probably not a lot because of my support, if I'm being honest. And I mean, it's hard to reflect on the ones where we wish we had done better. But she did it out of
That's
truly her own will and advocacy, and not a lot because of my support, unfortunately. But I learned a lot from it, and I'm glad that she was able to. And the other thing is that introduction to complementary foods might be more complex or a different timeline, but is also a process where we can support family goals as long as we, like you said, are being flexible with how we're approaching our goals, and knowing that there might be back and forth. We might, take a few steps, quote unquote, forward and then have to move slightly back and adjust based on what that infant needs and what that family needs.
Yeah.
And we know as clinicians, and the research supports it, that texture introduction, feeding skills, those might require a little bit more support than for other infants. But they can
But
absolutely
that's why this is why
that's why
we have occupational
we're here.
therapists. Yes, we have OTs to help us support with these skills, and PTs to help support with like the foundation for, because I can't teach a child to roll over, not my scope of practice, but you should know who in your community to refer to. And
Mm-hmm.
that is within our scope of practice to make referral request,
Yes.
which is us doing our evals and making notes. And it always surprised me how often I have seen caregivers in general not know that they were eligible for all of these extra services, right?
This is my
It's
soapbox, Michelle.
oh, but like also like yes, you might work in an area where like the EI system is like basically non-existent, but like so sometimes pediatricians just stop referring, and so the caregivers don't know, and it's like, okay, that goes just that. Okay, tell me about your soapbox. Yes.
Okay. Yes, because when I worked in
You
early
lit up like a
intervention,
Christmas tree. You were like, "That's my soapbox." You like yeah, sorry.
when I worked in early intervention, I cannot tell you how many times I went in to see a kid for speech and language, and I was going in for their regular session, and they happened to be eating a snack while I was there, and I was like, huh, did you know feeding therapy is an option and like I can do it? And the parents were always A, shocked, and B, so relieved. Like, oh, there's someone who can help me with this. Like, this has been such a struggle. I just thought I had to do it on my own. It never came up.
Yes. Yes.
So
Okay.
frustrating.
So resource number one for our caregivers is us reaching out to uh, our local EI system. And may I suggest, y'all, we can advocate that the PFD screening tool created by Feeding Matters, which is free and normed, is 6 questions, just 6 questions. They can incorporate that in their patient intake work, and that would flag a referral to the feeding therapist. And given locale or area, it could be an OT or a speech, or it could be both. And you can work with your favorite pediatricians to be like, hey, here's this tool. You can screen the parents, or when you're giving them the, what is it, the ASQ, like the
Mm-hmm.
developmental screen, you could just tack that in there. Okay, soapbox,
Mm-hmm.
done. Okay.
Other soapbox is that pediatrician piece, which we did a survey of families of young children with Down syndrome, and we asked them about whether they received information on introducing complementary foods, and the results were appalling. Less than 50% of families got information on when to introduce solid foods. Less than
Yeah.
40% got information on readiness signs. About 45% were told about how to introduce, and like 40% how to offer. And when we looked at compared to neurotypical kids in the same sample, I mean, it was 75-80% of families of neurotypical kids were getting this information, where far less than half of parents or caregivers of infants with Down syndrome were. Some research on PCPs has told us that they don't get a lot of education on Down syndrome, and so they just don't know what to say, so they don't say anything.
Yes. Um, I'm
Um,
I'm trying to find it. There was, and I just heard him. Um, hold on one second. This lovely gentleman, Dr. Ronald Serbin, Serbin. He's a pediatrician and had a webinar on Feeding Matters called Diagnosis Spotlight: Cracking the Code, Diagnosing PFD in Children from Diagnosis to Dinner, Breaking Barriers to Successful Mealtimes. Very long name for the episode or his presentation. But he talked all about the training that he received as a pediatrician to coach parents in this process, and then the realistic barriers for doing the screening. And it was everything you just said, and then terrifying, because he was
Mm-hmm.
like, we're not trained on how to tell parents what foods to introduce. And I was like, oh my gosh. And then the keynote speaker did like such a great job on it. But like,
Mm-hmm.
listening to Dr. Serbin like break down the scaries of it was like, oh, God bless America. Yeah.
Yeah, I mean, I just recently talked to a pediatric nurse practitioner who worked for 10 years and she had a special interest in Down syndrome. So she worked in primary care, but got a lot of the kids, and she was in a major metropolitan area. So she saw a lot of the kids with Down syndrome because she had a reputation for specializing in that. She told me in the 10 years of clinical practice, she thinks she referred for feeding therapy maybe 2 or 3 times.
Oh my gosh.
Mm-hmm.
Oh my
And she's like,
gosh.
I feel really bad about it now, but I just, unless their weight was, you know, it's exactly what we always hear and freak out about as clinicians is like, she's like, yeah, I didn't know about it. I didn't really think to ask families about it. And so unless their weight was falling off the curve, I just, yeah, never
Well,
considered
what
it.
blows my mind is back in South Carolina, well, my twin got thick. When I went far out to the Northeast, so like straight up, if y'all, I lived in Columbia, so if I went straight up 77, um, it got really, really rural out there, because you're going towards like the PD section of South Carolina. Or when I went straight down 20, like out west, it got very rural. And I would get on those outliers where socioeconomic status drops, I would get referrals for failure to thrive because kids, little ones with Down syndrome's weights had dropped. However, they were being BMI measurements on a regular, quote unquote, regular child and not on the Down
Down
syndrome
syndrome.
growth curve. And y'all,
Mm-hmm.
there within the population of Down syndrome, there is a unique growth curve. They have their own charts. And and that always boggled my mind. And I'm like, yeah, but mama, what growth chart are we using? Something that's simple. But I say that through the lens of having had the joy of working with lots of little ones that have Down syndrome, and reading a lot more into literature. And if you're, I can't fathom a pediatrician seeing 20 to 40 kids a day and you only see a little one with Down syndrome like once every couple of weeks, then I understand. I mean, give grace always. Okay, what other resources are you like, this is an amazing tool, excuse me, and we should be incorporating it in?
Yeah, the other thing that I want to mention, I mean, state level Down syndrome associations can be hugely helpful if you're not getting this kind of information from your pediatrician because often they don't know.
Yeah.
Connecting with parents who have experience, who are further along the journey, who can connect you with those providers who might have
Yes.
specialized in this. I think the state level Down syndrome associations can give you more of that feel and have better connections in your area. Um, the other thing that I want to mention is I have not explored all of their resources, but there is a resource called Down Syndrome Clinic to You. Have you heard of this?
No.
It's through Massachusetts General Hospital. There is a fee for it, although I do believe it's a sliding scale for caregivers. But there is a detailed process where you enter all of your child's information, all of their medical history, and it gives you timely guidance based on the Down syndrome specific guidelines of recommendations, things to look for. There's Down syndrome specific guidelines for specific medical tests that, a certain blood test you need at a certain age and things like that. This gives you personalized results that you can then, and a form that you can take to your PCP that says, these are the Down syndrome specific things that
Yes.
my child needs right now, which is pretty incredible.
Yes. I remember Columbia had a Down syndrome clinic in it. Um, it was out of the children's hospital there, but not all major you have to go to like major healthcare centers to like access a Down
Mm-hmm.
syndrome. Um, yeah.
Yeah. So that's why it's to fill that gap. If you actually UNC just opened a Down syndrome clinic like a few weeks ago.
That's
um,
amazing. Okay,
just
so USC has one. I know MUSC has one. I don't know if UVA has one now that I moved. I should probably find
yeah,
that out.
there's one in Charlotte for other North Carolina people.
Yeah.
Charlotte and UNC both have them in North Carolina. But if you don't have a Down syndrome clinic near you, this is another way online to get kind of access to
Yep.
those Down syndrome specific medical guidelines, so that your pediatrician can support
Yes.
you in those things that we know are super important for the Down syndrome specific population specifically.
Yeah. I love the National Down Syndrome Society's website. Full disclosure, my sister-in-law used to be one of their lobbyists. And so watching, she got an award for like her national level lobbying work and stuff like that. But and now she works for a mental health organization, which is just lovely.
Mm.
But lobbying for them at a national level. But what has been beautiful is, we've been at this a little while. I graduated with my master's in '09, so I've been out in the world. But watching the NDSS website evolve, and now they have so many resources specific for craniofacial, for GI, for cardiac consideration, and then embedded within. Also, I like how it's set up, so it's got like a picture, a title, and it looks like a card catalog. I love the simplicity of the card catalog. So you click it and then it pops out like a card catalog, like the old school where you like pull the drawer. I know I'm old people, but like that brought me joy. And so there's so many resources within that website. But y'all, there's two that additional ones. One of them, the National Foundation of Swallowing Disorders, for free every month. I think it's the second or fourth Thursday. They have a caregiver support Zoom call where you can hop on and meet other caregivers of children with pediatric feeding disorders. It's not unique just to individuals with Down syndrome, but it's a great starting point to like meet other community members. And then Feeding Matters has the Power of Two program that's free. And so you can click the Get Help button that's bright orange, top left corner of their website. So just click it and then reach out for the Power of Two program. And they do a really good job of partnering you with a been there, done that caregiver, which I kind of like. Um, because as a mom, there's things that I want to hear from other mommies before I take something to like the practitioner, because I'm like, hey, am I nuts? Just vet this for me. So yeah, like tell me if you think I'm being nuts, right? And yeah, but those are my biggies.
Yeah,
Yeah.
I think the Power of Two program is so fantastic because it's so valuable to hear from another family, and like you said, be able to bounce it off before you bring it up, maybe. We all have things that we're like, is this nuts? Like this
Normal.
lady's gonna think I'm nuts.
So when Bear got an inguinal hernia, which is where your muscles wall split and your intestines slip into the testicle. And I remember changing his diaper and his right nut got huge. It was like the size of a lemon. And I was like, I don't think that balls are supposed to do that, where one is regular size and the other one is like giant. So I called my girlfriend Tessa, who's a pediatrician. She goes, do not Google what I'm about to tell you. And I was like, yes, ma'am. She goes, no, promise me. And I was like, yes, ma'am. She goes, call Bartlett, Bear's pediatrician, right now and take him in. And I was like, okay. And so like I broke my promise and Googled it and then had a total panic attack. And we went straight to the pediatrician's office and he had surgery like a few days later. But yeah, But again, had I not had another mommy friend, I mean, I don't know what I would have done, but yeah.
Mhm. My
Also,
mom
friend,
always loves that
important.
we're covered well in our family because I'm a speech pathologist. I have a cousin who's a nurse. My brother's an accountant. She's like, we've got it. All the major advice that you would need.
Life, death, and taxes. You're covered literally from that's awesome. Oh my God. Oh, fantastic, honey. Okay. Kelsey, this is great.
Yeah,
Are you loving your research?
I am. Yeah, I just really, as much, I love clinical work because I love connecting with families. But I get to do that through my research as well, doing qualitative stuff, so people's experiences, and then a little bit more also on the quantitative side of
Yeah.
what does the data actually say, and it's the perfect combination. I need both.
Yes. Same. I like working in the clinic a couple days a week, being with my families because it keeps growing me. and
Mm.
and and I learn so much, and I like my Mondays because I can podcast. I grow from picking researchers' brains and colleagues' brains, and I get to do my volunteer work that I keep promising my husband I will do less of. But all the same, it I love it. It makes me very happy. And now that the time change has happened, which sucked that it was on my birthday weekend, but like whatever, we're gonna have homemade lasagna later. It'll be fantastic. Um, Getting in the garden because we've spent 2 years at this house literally tearing stuff out, and so this is the first year that we're at a point where we can put a little bit back in, and
Oh,
yeah.
that's so exciting.
Yeah,
Yeah,
we'll see how much the deer eat. I'm not. We're taking bets on that. So, and
yeah.
the loser has to buy milkshakes. So everybody
Good
wins.
deal all around.
Yes. Klein's. Y'all come to Stanton. If you come to Stanton, Virginia, you have to go to Klein's Dairy Bar. Black chocolate, black chocolate cherry ice cream and tater tots. Oh my God, great
Ooh,
combination.
yeah.
Okay, so if somebody's listening and they feel so inspired, do you have an entity or an organization that you'd like them to send a little love money towards?
That would be Feeding Matters. I've volunteered with them, admittedly, for a long time. And we talked a little bit about the power of two, but they have so many other great resources for clinicians and researchers and connecting all of us with the caregivers. And I think the work they do is so important. I am biased, of course, but
Thanks.
full disclosure, I am biased, but they are doing incredible work in the feeding space. And so I encourage everyone to check them out at the very least, and see what resources they have available. Even if you aren't in the feeding space necessarily, you are bound to come in contact with a child or a family. They have a provider directory on there. So there's tons of resources. And then also, if you have a little bit to give, I would encourage you to do so there.
Yes, awesome sauce. Well, Kelsey, thank you for making my birthday special. This is a fantastic way to kick it off.
Oh,
Yeah.
I'm glad. Yeah, please enjoy your day. This has been wonderful. Thank you so much for having me.
Honey, yes. Oh, wait, bloody hell, I almost forgot. What if somebody has a question for you? How do they reach you?
Yeah, please do. And if you're a clinician who is interested in research or interested in early feeding and research, or you have a great research idea, I don't do as much clinical work now, but I want all of my research questions to be founded in something that's going to be clinically relevant. So please reach out with ideas, thoughts, case study, anything. I am best reached at Kelsey_Thompson. So my first and last name with an underscore at med.unc.edu.